Okay, yang ni, yang saya cakap ni, okay, this is the temporal retina. Temporal retina of the right eyeball akan receive nasal vision. Dia akan receive light ray from the nasal visual field. Okay. Temporal retina ni akan receive nasal light ray from the nasal. Dia akan jatuh kat sini. Faham? Nampak tak? Dia akan jatuh macam tu. Sama juga dengan ni lah. Sama juga sebelah sini. Sebelah sini yang belah left ni, temporal retina ni akan receive yang ni temporal retina of the left eyeball akan receive nasal vision of each. Dia punya sendiri, dia punya ni lah. Dia punya visual field dia. Faham tak? Faham tak? Okay?
Okay, so far everybody understand or not? In which
Faham tak semua?
what Ainis is presenting is that the light ray akan masuk towards different direction. The nasal view, anything from nasal, light from the nasal will be projected to the temporal retina. And then whatever coming from the temporal, any light, any object from the temporal view, temporal outside from the temporal, will be projected onto the nasal retina. Okay, ni baru kita punya this yang you all need to understand supaya later bila pergi ke belakang you akan understand macam mana the visual field defect to occurs. Okay, so far everybody can understand?
Yes,
Okay.
Doctor.
Okay, I need proceed further.
Okay. Okay. Doktor dah simplifikan. Okay. Lepas tu, okay, kita punya temporal lobe ni, temporal retina akan turun ipsilaterally. Temporal retina of the, kita tengok, kita fokus on the right eyeball lah. Temporal retina kita, temporal retina fibers kita akan turun on the same track. Maksudnya dia akan turun this is the right temporal retina akan turun to the right temporal right optic tract. Okay. Macam ni. Sama juga kat sini. This is left temporal retina. Kat sini dia akan turun to the left optic tract. Okay. Itu untuk temporal retina. Why? For the nasal retina fiber for each eyeball, dia akan cross dekat bahagian optic chiasm. Kat bahagian sini. Okay. Kat sini, this is nasal retina tadi, nasal retina fibers yang receive light ray from the temporal part akan cross dekat bahagian optic chiasm. Ini right kan? This is a right nasal retina fibers akan cross go to the left part ataupun left optic tract. Why? For the left, this is the left retina fibers. Dia akan left nasal retina fibers akan cross ke optic chiasm dan dia akan pergi to the right optic tract. Okay? Faham? Okay. So next. So bila dah berlakunya cross section apa semua tadi, dia akan membentuk tract dekat situ yang menyebutkan optic tract. Itu yang berlakunya ada optic tract. Optic tract ni satu dia menerima temporal ipsilateral punya fibers dengan satu lagi ada contralateral punya fibers. Okay? Satu, dua. Okay, faham tak? So bila these fibers dia akan pergi to the thalamus. This is lateral geniculate body ni ada di dalam thalamus. So bila dia pergi kat situ, dia akan keluar menjadi two type fibers pula. Dia akan there's a fibers that come out from the lateral geniculate body, which firstly dia akan run through the temporal lobe. Dia akan run through the temporal lobe to go to the occipital lobe. That's why kita panggil sebagai temporal lobe. Temporal lobe sebab temporal lobe ni bawah sikit. Bahagian lalu ni bawah sikit, so kita panggil sebagai inferior retinal fibers. Inferior retinal fibers. Okay. While for the parietal lobe ni, yang ni, dia adalah salah satu fibers yang keluar daripada lateral geniculate body juga yang akan pergi to occipital lobe melalui parietal lobe fibers. Parietal lobe fibers ni ataupun kita panggil sebagai superior retinal fibers. Ada kepentingan tahu inferior dengan superior sebab nanti defect dia ada yang tu. Okay. And then bila dia dah keluar and then dia jalan, lepas tu dia akan membentuk lagi satu jalan yang sama. Dia akan berjumpa balik and then dia akan menjadi optic radiation. So both ni akan go to the occipital lobe kat sini, occipital lobe. Faham ke semua? Okay, next. Okay, yang ni saya nak cakap, this is what we will discuss later. This is a right visual field. This is kita punya visual field akan boleh divided into the right ataupun left visual field. Okay, and then also dia boleh divided into the 4 quadrant, which is superior part, superior, left superior visual field, ataupun this is left superior yang sebelah dia yang kosong tu, yang tak ada tulisan tu, right superior visual field. Yang bawah tu left inferior visual field, yang sebelah yang kosong tu juga right inferior visual field. Okay, kita akan discuss benda ni juga. And then also kita akan discuss pasal macular area. Okay, ni visual field defects lagi. Okay, next. Okay, you guys faham kan yang punya pathway, visual pathway tadi kan? So yang ni kita nak cerita pasal defect. Okay, so firstly A, there is optic nerve damage ataupun defect. And then B, optic chiasm. Ada berlakunya damage kat optic chiasm. So ada dia punya its own defect lah. And then optic tract, ada berlakunya damage kat optic tract. Ada berlakunya damage dekat medial lobe ataupun inferior retina fibers. Yang ni parietal lobe fibers ataupun superior retina fibers. And then berlakunya something wrong dekat optic radiation. Ada berlakunya wrong dekat occipital lobe, occipital cortex. And also ada something wrong kat retinal fibers, also akan menghasilkan visual field yang berbeza-beza lah. Visual field defect yang berbeza-beza. Okay, so we go to the first one A. So bila berlakunya kerosakan dekat optic nerve, maksudnya kita losing visual field. Kita losing retinal fibers from the temporal part, temporal retinal fibers of the right eyeball. Sebab kita tengah fokus from the right side Kalau left side lain pula dia punya ni presentation. So kalau optic nerve ada berlakunya kerosakan right optic nerve, so maksudnya kita punya temporal lobe, kita punya temporal retina fibers tak boleh menerima nasal, tak boleh menerima light ray from the nasal, right nasal. That's why kita ada berlakunya, that's why kita punya ni, nampak tak yang warna itu hilang. That's why kita punya right vision kita hilang kat situ. Yang ni dah kita tak boleh terima information from this. That's why kita tak dapat terima right from ni. Sebab tu kita tak nampak tu. And then kita also losing the nasal retina fibers from the right eyeball. So bila kita tak boleh menerima nasal retina fibers, kita tak boleh menerima light ray from the temporal part. Tak boleh terima daripada situ. So that's why kita pun hilang kat situ. Faham tak semua? Okay, that's why kita panggil sebagai right monocular blindness. Maksudnya monocular tu satu part je, satu bola tu. Okay? And then berlakunya, and then B pula. B pula, if there any pituitary adenoma ke, yang compress dia laluan tu, compress optic chiasm tu, yang menyebabkan kita punya fibers tak boleh nak lalu. Okay, bila kita tahu kan optic chiasm ni adalah tempat cross of the nasal retinal fibers from each eyeball. So perasan tak? This is bila kita hilang, kita tengok atas ni yang warna hijau ni. Yang warna hijau ni bila kita go up, this is nasal retina fibers kan? So nasal retina fiber ni, yang ni. Yang ni kita terima daripada temporal fiber, retinal temporal field ni. So kita hilang. Kita hilang ni. Tengok kat dalam box tu. Itu. Yang warna hijau. Kita also hilang yang warna oren ni. Sebab fibers kat sini tak boleh lalu kat optic chiasm tu kan. So that's yang ini. Kita hilang yang ni pula. Yang ni kan nasal retina fibers kan. Nasal retina fibers akan terima from the temporal field kan. So sebab ini kan left eyeball. So kita tak boleh menerima from the left temporal field. That's why kita hilang ni juga. Okay. So that's why kita panggil ni sebagai bitemporal hemianopia. Yang B ni. Okay. Faham semua? And then C. C ni, C bila berlakunya ada damage kat optic tract, nanti kita tengok apa causes dia. So yang ni kita tengok atas, kita ikut dia punya fibers yang kat atas. Okay, yang merah ni kita tahu kan yang merah ni adalah temporal retinal fibers kan. Temporal retinal fibers akan terima nasal retinal fibers kan. Ni right kan sebab dia ipsilateral. So ini right, yang ni right, yang ni. So ini hilang, kita hilang yang ni. Kita hilang ni. Tak. Okay, nampak yang sekali kat tepi tu, yang dalam box C tu. And then kita ikut juga yang line kuning ni. Kita hilang line kuning ni juga. So hilang line kuning ni adalah nasal retinal fibers of the left eyeball. So maksudnya kita hilang light ray that come from the temporal field of the left visual field tu lah. That's why kita hilang ni. Kita hilang temporal tu. Kita kena ikut fibers ni balik. Jadi gitu. So ini kita panggil sebagai left homonymous heminopia. Kenapa left? Tadi ingat tak saya tunjuk kat awal-awal tadi? Before slide ni, saya tunjuk ada left visual field dengan right visual field kan? So left, this is yang effect ni. Yang defect ni adalah left visual field. Ni kan right, ni kan left. So this is left visual field. Okay? Okay, harap semua faham. Okay, D pula. Okay, bila dah berlakunya dah bertukar-tukar semua, dia akan pergi dekat lateral geniculate body kan, and then dia akan keluar two type of fibers. Saya cakap tadi temporal medial lobe ni ataupun temporal fibers ni ataupun kita panggil sebagai inferior retinal fibers ni. Daripada nama dia pun inferior retinal fibers. Maksudnya kita menerima light ray from the superior. Betul tak? Inferior retinal fibers akan menerima light ray from the superior light ray. Sebab superior light ray akan jatuh ke atas inferior retinal fibers. Bila jatuh atas tu, bila berlakunya defect dekat inferior retinal fibers, maksudnya kita tak boleh menerima cahaya from the superior part. Tapi memandangkan dia ni adalah di sebelah kanan, so kita tidak boleh menerima from the left vision field, from the each eyeball. So that's why yang D ni kita nampak. Okay, tadi saya cakap yang temporal lobe ni dia menerima light ray from the superior. Okay, bila berlakunya ada defect kat sini, that's why dia punya superior yang hilang. Tapi which side? Right ke left? Sebab medial lobe yang defect ni sebelah kanan. So dia akan jadi belah kiri. Yang light ray from dah kiri yang kita tak boleh nampak. Visual field from dah kiri yang kita tak boleh nampak. So that's why dia jadi left superior quadrant tanopia. Okay, faham tak yang D ni? Why? For the E ni, nama dia parietal lobe fibers. Okay, yang ni. Ataupun kita panggil sebagai superior internal fibers. Okay, superior retinal fibers. Okay, kalau superior retinal fibers ni akan menerima light ray from the inferior. Sebab dia superior kan, duduk kat atas, light ray akan datang daripada inferior masuk ke, akan pantul kat superior. So bila berlakunya defect on the superior retinal fibers, kita tak boleh menerima cahaya from the inferior. So maksudnya kita tidak boleh nampak in the inferior part. Okay, that's why kita tak boleh nampak inferior part. Inferior ni kat bawah ni lah. Tapi which side? Kiri ke kanan? Kiri. Sebab yang rosaknya dekat bahagian right parietal lobe fibers. That's why kita jadi left inferior quadranotopia. Faham tak? Okay. Then we go to the F, which is optic radiation. Optic radiation ni dia dah tak jadi 4 kuadran dah. Dia akan jadi balik 2 kuadran sebab gabungan 2 ni. Dia dah bergabung balik. Parietal lobe dengan medial lobe ni. Dia akan gabung, so that's why. Okay. Tadi saya cakap apa benda yang kiri dia akan jadi kanan kan. Sekarang ni yang defect ni sebelah kanan. Yang defectnya bahagian belah kanan. Kita punya berlaku causes damage ke belah kanan kan. Ni kan kanan kita. So yang defectnya visual field belah kiri. Sebab tu nama dia left homonymous hemianopia. Kat sini. Left visual field. Left visual field from each eyeball. Okay. And then G. G pula occipital cortex. Kenapa occipital cortex? Okay, kita tahu. Kita punya occipital lobe ni menerima two type of blood vessel. Two type of blood supply. Which is from the posterior cerebral artery dengan medial cerebral artery. Okay. Medial dengan posterior ni, dua-dua akan supply ke occipital lobe kan. If there any blockage from salah satu ni, contoh ada berlakunya blockage from the posterior cerebral artery, kita punya medial cerebral artery akan still menjaga occipital lobe. Cumanya, dia akan, dia nak menjaga macular part of the macular part in the occipital lobe. Sebab macular part ni adalah part paling penting in our vision. So that's why dia akan still preserve. Based on dia punya nama G ni, left homonymous hemanopia. Sebab right part kan. So dia akan defect on the left visual field. Cumanya perasan tak ada bulatan kecil tu. Bulatan kecil tu di preserve disebabkan blood supply tu still ada untuk preservekan the macular part tu. So itu G. While for the H pula, there is macular fiber ataupun there is a defect in the macula. Macam ada certain disease yang boleh menyebabkan macular fibers kita rosak. Tapi sebelah kanan kan, perasan tengok betul-betul yang gambar H tu, kalau kita tengok, dia punya bulatan kecil tengah tu, dia bukan bulatan tau sebenarnya. Dia hanyalah left side. Dia bulatan, tapi dia belah kiri je yang kena. Dia tak sepenuhnya bulat sebab yang belah kanan ni belah sini. Belah sini tak ada apa-apa. Macular fibers yang belah kanan otak yang defect. That's why kita punya macular vision belah kiri kita yang defect. Faham tak semua?
Okay, everybody understand?
Faham.
Faham. So I don't need to repeat anymore, okay? Kalau semua orang dah faham. To make it simple, anything before chiasm, maksudnya yang optic nerve before chiasm adalah optic nerve sahaja, right? So anything on the optic nerve, dia akan, because optic nerve carries from one eye, so the blind is only on one eye lah, on the affected optic nerve. So right optic nerve damage, right optic nerve disease akan cause right monocular blindness. Okay, anything retrochiasmal, which is after the chiasm. Chiasm is closing kan? Nama pun dah cross. So anything after the chiasm, retrochiasmal, dia akan cross dan the defect is on the, walaupun on the right optic tract, but it is after closing, jadinya the defect is on the left. Okay, so right optic tract will cause left homonymous hemianopia. Samalah dengan yang lain. Okay, so same thing juga, whatever your eye perceive, the temporal vision received from nasal, the temporal vision will be fall on the nasal fiber. Yang nasal punya field akan fall on the temporal fiber. Superior field jatuh pada inferior fiber. Inferior field jatuh pada superior. Everything on the eye is terbalik. Okay, alright. So if no more question, we proceed to the next slide.
Okay, tengok tak? Okay, so this is the defect. Okay, contoh dia for monocular blindness, the causes thromboembolic, stenotic vascular disease, vasospasm, retinal migraine, close angle glaucoma and papillary edema. Papillary edema akan dipresent oleh kawasan nanti. And then bitemporal hemianopia. Okay, sebab saya cakap tadi, if there any pituitary adenoma ke, pharyngioma ke, meningioma yang compress the optic chiasm tu. So that's why dia jadi bitemporal hemianopia. Okay, next, homonymous hemianopia, causes this stroke ke, traumatic brain injury, brain tumor, and then superior quadrantenopia, stroke, tumor, damaging posterior visual pathway, aneurysm, demyelinating disease, trauma, abscess, and renosis, while the inferior quadrantenopia, neoplasm, inflammatory process, ischemic ataupun infection. Yang membezakan semua ni adalah the location of the stroke tu. Tadi kalau faham yang defect tadi, kalau superior maksudnya ada defect on the superior vision kan. Maksudnya the stroke ni dekat inferior retinal fibers kita. Bila ada stroke kat inferior retinal fibers, sebab tu kita tak boleh terima superior vision. That's why kita punya ni, dia depends on the location of this disease ni lah. And then homonymous hemianopia with macular sparing. Macam saya cakap tadi, kita punya hospital loop menerima two type blood supply. So yang contoh disease ni pun menyebabkan blood supply, which is occlusive cerebrovascular disease, cerebral obstruction ataupun intracranial hemorrhage yang menyebabkan kita punya salah satu blood supply kita terputus. Hanya ada satu blood supply. So dia akan preserve the macula tu. Okay. And then next. Okay, this is ada visual field defect. Contohnya macam tunnel vision. So tunnel vision ni adalah loss of peripheral vision. Tapi central vision kita nampak. Contoh disease dia glaucoma. And then secondly, long standing papillary edema affected retinal abnormalities. Okay, faham tak? And then scotoma. Scotoma ni an area of diminished vision within the visual field. Kita ada central scotoma, ada peripheral scotoma. Kalau central scotoma ni kita diminish kat bahagian central lah, which is retinal macular disease. Kalau peripheral scotoma, retinal holes, retinitis pigmentosa. And then lastly enlarged blind spot. So kalau enlarged blind spot, dia punya causes adalah features of optic head enlargement. Sebab tadi saya cakap blind spot ni adalah light ray yang jatuh on optic disc. So bila makin besar optic disc tu atau optic head tu, makin besar lah kita punya blind spot. Contoh disease dia papilloadenoma. Okay. Doktor,
Ya.
nak tanya, apa beza tunnel vision dengan peripheral scotoma?
Okay, tunnel vision ni macam you all pakai binocular, pakai apa kita panggil tu? Teropong. Can you imagine you use teropong kan, you use binocular. So what you see is just macam tengah kecil saja. You tak nampak dah tepi-tepi kan? That is tunnel vision. But peripheral scotoma ni dia macam patchy sahaja. Dia bukannya habis the whole peripheral vision. Kalau you imagine 360, kalau macam mana nak cakap kalau central scotoma you faham. Kalau you tengok dekat gambar bawah yang ada enlarged blind spot tu kan, hitam tu adalah blind spot. Okay, yang hitam tu adalah blind spot. Okay, jadinya kalau central scotoma berlaku dekat crossing tengah tu. Nampak tak?
Yang ada crossing ni, okay.
Crossing tengah tu. Setiap satu dot tu you nampak ada dot dia tu kan? Setiap yang besar. Setiap satu tu adalah 10 degree. So anything within 10 degree tu adalah central scotoma. But peripheral scotoma ni, if peripheral scotoma dia boleh, maybe dia happen dekat nasal sahaja. Nasal periphery. Maybe dia jadi dekat temporal ataupun maybe dia boleh jadi dekat superior tapi tepi sahaja. Tak involve the inferior. Okay. Tapi kalau tunnel vision ni dia preserve within the 10 degree yang tengah-tengah tu, tapi tepi semua memang dah hitam. Faham tak? Macam you tengok enlarged blind spot tu, the colour hitam tu fulfill the whole yang kat tepi, tapi dia cuma tinggalkan center 30 saja. You imagine dia reverse pada central scotoma. Tunnel vision is reverse of central scotoma.
Reverse. Okay.
Okay, so central scotoma dia kacau tengah, tunnel vision dia kacau the whole tepi, dia preserve tengah.
Okay. Boleh nampak.
Alright.
Okay. Thank you, Doktor.
Okay.
That's all from me. Thank you.
So, okay, I will continue with anatomy of pupillary reflex. Alright. So for this first, I think you listen first, nanti I explain later. Okay, so anatomy of pupillary reflex start when the light go through the retina, and then it will be sent to the optic nerve, flow to the optic chiasm, and then the information will be decussation like I explained before, and then we flow to optic tract, go to brachium of superior colliculus, and then go to midbrain, retector nucleus, and then go to ipsilateral and contralateral and gingival nucleus, ipsilateral and contralateral oculomotor nerve, ipsilateral and contralateral ciliary ganglion, and then go to ipsilateral and contralateral short ciliary nerve, and then go to ipsilateral and contralateral sphincter muscle of iris, which is the result is constriction of the pupil. So this one maybe you can see more simple and more lagi senang nak nampak. So for example, when the light go to the left eye, as I said before, it will pass to the retina, and then it go to the optic nerve, and then flow to the optic chiasm, which is then the information will be decussation, which is form an X, and then it go to optic tract, and then pretector nucleus. And as you remember, I said about the ipsilateral and contralateral. So ipsilateral is the same pathway, and the contralateral means the next the contra pathway. So for the ipsilateral and contralateral, so for the left eye, it means the ipsilateral and linear vesical nucleus. And for the right eye, it will means as contralateral and linear vesical nucleus. And it flow, as I said before, to oculomotor nerve, which is ipsilateral and contralateral, ciliary ganglion, short ciliary nerve, sphincter pupillae, and then it will cause constriction of the pupil. Boleh faham ke?
Boleh.
InsyaAllah
Okay.
boleh.
So
Alright.
Boleh.
light reflex involve which nerve? Involve which cranial nerve? Okay, so optic nerve is your second, right? And then we
Yes.
pergi to the superior corticulus of the brachium tadi tu, the protector nucleus. It is belong to the third nucleus.
Okay.
Okay,
Okay, third nucleus.
alright. Okay, continue lagi.
Okay. So these are the pathway. So as you can see for the light and image there. So you can see here the light. Okay, so it will pass through the, and then the butterfly ni this one, okay, you imagine the information lah. So as I said, go to the optic nerve, opticism, and then it will be decussation at here at the opticism. Oh, okay. And then it will go to optic tract, protector nucleus, and continue as I said before. Right. So for the pupillary reflex assessment, first we have direct pupillary light reflex. So the principle is first we minimize the accommodation by fixing eyesight onto distant immobile object, which mean kita biar mata patient tu static dekat satu tempat je, jangan tengok kiri kanan, just static satu tempat. For example, suruh tengok dinding ke atau satu objek yang fix, and then we shine the light, which is pentosh, to the side of the left eye, and the left eye kita akan nampak the pupil will constrict. So same goes if kita nak access the right eye, so we shine the pentosh to the right eye, and then we can see the pupil will constrict. As macam illustration of the gambar tu, kita nampak the left eye constrict the pupil. And then for the consensual pupillary light reflex, kita kena for the principle, two pentosh are needed. To access the left eye, shine one pentosh onto the left eye from below, and then shine another pentosh onto the right eye from the side. So we observe for pupillary constriction on the left eye. Maksudnya, mata yang kita nak access, which is the left eye, kita akan suluh daripada bawah, and kontra punya mata, lagi satu, kita akan suluh from the side. Tapi doktor, saya nak tanya, seingat saya, kalau yang kami belajar macam letak tangan dekat tengah-tengah, boleh juga ke?
Oh, tak payah, kita tak payah guna tangan. Basically, it's about what we do is that when you are doing the direct pupillary right reflex, you point the light in front. Because kalau you shine daripada side, the light macam akan cross sikit kan, except for those yang berhidung mancung. Jadinya kat sini the statement ni kita kena betulkan sikit basically. Okay, macam ni. Okay, I explain. Untuk pupillary examination, one of it is pupillary reflex. But I nak start daripada awal. So bila we assess pupil, first you nak tahu the size of the pupil. So if you want to know the size of the pupil, you don't want to shine directly, not in front. So kita akan suluh daripada bawah. Kita nak tengok roughly how big is the pupil. Is it 3 or dilated? Is it 2 or 3 ataupun dilated? So kita punya shine itu perhaps kalau I akan buat daripada bawah. Okay, so kita boleh nampak. You suluh from bawah, you can see berapa size the pupil and then whether it is round or not. Okay, so dah nampak the shape, the size, then you shine from the side. the light come from the side and then you move to the front. Sorry, you nampak tak? You tengok dekat yang I buat. So the light daripada tepi, you gerakkan ke depan mata patient macam tu. So sebabnya kita nak tengok, ataupun you boleh buat sini je, you boleh suluh daripada tepi and then remove. Suluh daripada tepi and then remove. That one is nak tengok the reactivity of the pupil. Is it the pupil tu respond tak pada light? Then only you proceed with pupillary reflex. So to do pupillary reflex assessment, okay, so kita akan shine dekat tengah. Kita shine kat tengah. So and then masa kita shine tu ataupun tepi sikit, and then kita tengok what are the size of the other eye juga. Okay, tak perlu tutup pun tengah ni. Sebabnya you are not shining dengan bright light yang, sebab kita tak guna lampu yang terang sangat pun basically. We just use our pen torch in which the shining tu takkan sampai ke sana pun, you tak perlu cover. Alright, so you just directly macam tu and then tengok the other eye juga. Okay, to do consensual, satu dekat depan macam ni ataupun bawah sikit sebab you nak tengok kan. The other torchlight is dekat bawah. Alright, so you shine sini but you are looking dekat sini, dekat the other eye. Why? The concept is kalau you shine from below, you tak shine directly. So the eye takkan dapat apa-apa innervation pun basically. Cahaya tu sikit je malap-malap. So you boleh tengok the reaction of the other eye yang being shown. Faham tak? Susah sikit lah nak explain. Tak ada practical ni. Okay. Tapi the konsep yang you nak tutup dekat tengah-tengah tu tak perlu. We don't use that. Okay.
Okay.
Right.
So next one is the swinging light test. Also is a name also relative afferent pupillary reflex. So first, relative is the one light is less sensitive to the same light stimulus than the other, and the afferent it involves the sensory of optic nerve or retina component. And we have a defective eye which is RAPD positive. Relative afferent pupillary defect will not constrict fully upon shining but will exhibit consensual light reflex. For the principle, assess for retina and optic nerve function, and kita minimizekan accommodation by fixing eyesight onto distant or immobile object macam tadi. And then we prepare one pen torch and shine onto the left eye, and then we can see both eye will constrict spontaneously, and then kita akan swing the pen torch to shine the right eye pula. And then the same result will occur, which is the both eye will constrict spontaneously. For swinging motion is actually for buy time for the both eye to dilate first before constricting. So kalau tak faham, okay, saya ada satu video nak tunjuk. Okay, macam kita nampak kalau normal dia swing for both eye dia akan constrict.
Okay, yang for the swinging tu, macam dalam gambar tu dia buat terus sebelah ke sebelah kan. Want to buy time, so in real life, kita buat, okay, after shine the right, and then kita go down, it's like macam buai, kita buat macam pendulum movement. So right, and then kita swing to the left. Okay, so sebab bila you punya tangan bergerak macam tu, itu macam proper buying time. Kalau you buat macam ni, takut you gerak laju sangat, so the eye tak sempat dilate. So yang you tengok adalah the remaining constriction from the previous shining the other eye tu.
Faham?
Okay? Alright.
Okay, so just video ni nak tunjuk kalau dia ada the RAPD, so we can see that the constriction tak resolve dulu macam doktor cakap tadi. Alright, so next one we have accommodation reflex. So the principle, kita minimizekan accommodation by fixing eyesight onto distant or immobile object sama macam tadi. And then kita, the patient is asked to look at the object in 20 cm from his or her eye. We can use for example kita punya thumb sendiri. And then the result which is also known as near response triad. First accommodation will increase in antero-posterior diameter of lens, convergence and pupillary constriction. So kalau nak hafal, ada satu cara yang mudah which is kita hafal 3C. which is kita akan nampak constriction of the pupil due to increased of focus, and then convergence of the eyeball, which image forms in the corresponding point of retina, and the curvature of the lens increase due to increased power of lens. So I will continue with the papilloedema. So this is the normal optic disc. So we can see that macam picture atas tu, the disc yang paling besar and the cup yang kecil macam terang sikit tu. So we can see for the disc, the well-defined margin, and then the central retina artery and vein enter the globe slightly nasally in the optic nerve head, and then the pinkish rim with white central cup. Yang bawah ni macam illustrated yang gambar betul of the normal right eye. So for the papilloedema, so it's actually the swelling of the optic nerve head secondary to increase intracranial pressure. So kena ingat, papilloedema memang the swelling secondary to increase intracranial pressure and almost always bilateral, and is to rule out intracranial space occupying lesion, and all other causes of this edema without raised intracranial pressure is called dyswelling or dysedema. So kalau tak ada intracranial pressure increase, it's not papilloedema. Okay. So for the causes of increased intracranial pressure, first have any tumor or space occupying lesion of central nervous system, and then the decrease of cerebrospinal fluid resorption, for example, venous sinus thrombosis, inflammatory process meningitis, and subarachnoid hemorrhage. Next is increased cerebrospinal fluid production, for example, due to tumors, obstruction of ventricular system, cerebral edema or encephalitis, idiopathic intracranial hypertension, for example, pseudotumor cerebri, and severe systemic hypertension, and for example, malignant hypertension where the systole is more than 220 and the diastole is more than 120. And the medication, tetracycline, nalgesic acid, and iron therapy. So for the pathophysiology, first, the intracranial pressure will be increased, and then the pressure will be transmitted to the optic nerve through the optic nerve sheath, and then it will compress nerve fiber at the lamina cribosa. As you can see, the picture yang belah kanan bawah tu, the lamina cribosa tu nampak tak antara nerve fiber and the optic nerve. Okay. And then it will impair intracellular transport within the nerve axon, which is due to the compressed nerve fiber dekat lamina cribosa tu. The compression of central retinal arteries and the vein akan lead to vessel obstruction. And then it will build up material at the level of lamina cribosa, and then dia menyebabkan the swelling of the optic disc. Okay, macam gambar atas tu, we can see the box in red tu, warna kuning tu is the papilloedema. Alright. So for the clinical features, is the raised intracranial pressure symptom is headache, worse while walking and coughing. And then nausea and projectile vomiting. Neurological symptom kalau ada involve of space occupying lesion, and then to rule out head injury, which is indicate subdural hematoma. And the vision usually normal except in very advanced disease. Okay, and then you can see other clinical features is obscuration of vision, which is the graying out of their vision, especially when rising from a lying or sitting position. So obscuration ni macam transient loss of vision lasting a few seconds, which is the graying out tu. And then the normal color vision, especially the color vision stay normal, and then large blind spot, absent relative afferent pupillary defect, and the may associated with cranial nerve six palsy, which is diplopia. Alright. So for the finding, we can see optic disc appear hyperemic and raised above the level of retina, and then the disc margin are blurred initially at nasal, and then later it will go to superior, inferior, and temporal. So you can see between the normal and the papilloedema, the margin will be blurred. You cannot see truly the round margin. Okay. And then it will loss of physiologic cupping, and the central vessel on the surface of the disc are displaced forward. Retinal veins are dilated, and there is nearly always a loss of induced venous pulsation. And in advanced stage, there may be hemorrhage around the disc, secondary optic atrophy, and exudate. So this is the grade 1 of the fundus. Kita akan nampak fundus finding of the grade 1 where the C-shaped halo that is subtle and grayish with a temporal gap which is obscures underlying retinal details, disruption of normal radial nerve fiber arrangement striation and the temporal disc margin normal. Okay, doktor, saya nak tanya sebenarnya the C-shaped halo tu nak tengok yang mana satu kan?
Okay, tengok dekat this is right eye. Okay, so
Mhm.
anything kalau you punya previous slide you did mention yang initially swelling part will be on the nasal. So yang you nampak yang blurred out is the nasal, superior superior quadrant, nasal and inferior quadrant. Betul tak? It's like 270 lah kat sini. That is C. But the temporal punya margin still clear, still distinct. Right. Nampak tak?
Yang ni ke doktor?
Yes, tu.
Oh, alright.
Okay. Ini yang kita panggil C-shaped halo.
Oh,
Okay, so to easy understand dengan nak easy remember, just remember grade 1 minimal degree of edema C-shaped halo ataupun nasal shaped halo. Nasal halo. Then go to grade 2.
okay. For grade 2, okay, kita akan nampak circumferential halo which is the blurry tu.
360.
So kita akan nampak 360. Okay. Alright. So and then elevation of nasal border and no major vessel obscuration. Doktor, untuk elevation ni sebenarnya senang nampak ke?
Elevation you can only see using the slit lamp.
Oh, alright.
PIO. Using kalau kita ambil fundus foto sahaja, you tak dapat nak perceive the elevation sebab it is a 3D punya image kan, 3D punya perception. So you nak tengok 3D, you kena use your binocular vision, in which gunalah slit lamp ataupun PIO lah, kita punya ophthalmoscope. Direct fundoscope tak dapat juga.
So next. Okay. And then for grade 3, kita akan nampak obscuration of more than one segment of major blood vessel leaving disc. Macam tadi kita nampak, dia clearly kita nampak dia masuk optic disc tu. Okay, kalau kat sini kita nampak macam dia dah mula kabur-kabur, macam tak nampak sangat dia masuk. So focus, and then still ada circumferential halo, elevation for all borders, and halo if we have irregular outer fringe with finger-like extension. So for grade 4, kita akan nampak total obscuration on the disc of a segment of a major blood vessel on the disc, which is kita tak nampak dah dia masuk dekat dalam optic disc tu, dah hilang, dah hidden. And then elevation, whole nerve head including the cup sendiri, and then the border obscuration is complete and the halo is complete. So for the last one is the grade 5, the obscuration of vessel on the disc and the leaving disc. Kita dah tak nampak masuk mana-mana vessel dah dekat bahagian optic disc tu. This is a severe degree of edema. Okay, so for investigation, we have several. For first, kita ada BP check, blood pressure check to rule out malignant hypertension yang more than 120 systole tu and more than 220 for systole and then more than 120 for diastole. And then for the perimetry, it's assess visual field, which is blind spot enlargement and convalescing. In chronic papilloedema, kita akan nampak constriction of visual field occurs, especially inferiorly, gradually causing loss of central equity and total blindness. Then for the lumbar puncture, untuk access cerebrospinal fluid for infection, for example meningitis and subarachnoid hemorrhage, B-scan ultrasonography to rule out buried optic disc brucine, and the radio imaging, which is CT scan and MRI, to detect any space occupying lesion or enlargement of ventricle. For management, the aim is to tailor to the underlying pathological process and the progression of the ocular finding. Untuk betulkan the underlying pathological process lah, because as we know, the swelling is secondary to the intracranial pressure. So kita kena betulkan dulu the intracranial pressure tu untuk betulkan the papilloedema, untuk rawat papilloedema. So for the medication, diuretics such as oral acetazolamide, carbonic anhydrase inhibitor to decrease the production of cerebrospinal fluid. And it useful in idiopathic intracranial hypertension but not in venous sinus thrombosis. The next is corticosteroid for inflammatory disorder, for example sarcoidosis, And then cryptococcal meningitis and TB, kita kena rule out dulu. Alright. Post-surgically, the underlying mass lesion, if present, kita patutnya remove. Kita patut remove the underlying lesion, mass lesion. And then we can do ventricular peritoneal shunt, which is bypass the cerebrospinal fluid. And then the optic nerve sheath decompression. Kita reserve for worsening ocular symptom in case of medically uncontrolled idiopathic intracranial hypertension, to create a small hole or window in the sheath surrounding the optic nerve to drain the cerebrospinal fluid and reduce pressure in the anterior optic nerve. And then the weight reduction and diet control is curative in the idiopathic intracranial hypertension. And then that's all.
Okay, any questions on Nisa's presentation? Whether it is the pupillary examination tadi, assessment, ataupun the convergence accommodations dengan papilloedema. Ataupun you all boleh keep dulu the questions, kita akan go back later after this. Okay, I think kita go back after this.
There is no question, then I'll proceed and move. The topic I'll be discussing with everyone today is optic neuritis. Next slide. So this is the outline of today's presentation. I'll first discuss on the definition, and next will be classification, clinical features, investigations, and also principle of management. So in this case, the principle of management, including the investigation or treatment, is very important because it is based on the classification. So our classification is also important. Definition of optic neuritis, inflammation and demyelination of optic nerve. Right, next slide. So we can actually classify optic neuritis based on a few groups. First group is through ophthalmoscope, what you see under fundoscope, right? And the next one is the etiology of optic neuritis. So under fundoscopy, we can actually see three kinds of presentation of the optic fundus. So the first one is retrobulbar neuritis. So by the term retrobulbar, you can know that bulbar means cranial nerve, right? Cranial nerve. Which cranial nerve? Cranial nerve number 2, which is the optic nerve. Retro means behind. So this kind of fundoscope finding, this kind of optic neuritis happens behind the optic nerve. Second one is papillitis, which is the most common.
Oh, sorry. Retrobulbar means the eye, the globe. So the retrobulbar, it is on the optic nerve to the back, but not interfering the optic disc head, the optic head. Okay, so it can still be on the optic nerve itself.
Right.
Okay, continue.
The third one is neurorhinitis. And for etiological causes, there are 4 types. The first one is demyelinating, which is the most common, especially in USA. The second one is para-infective. Third one is infective causes, and the fourth one is autoimmune. Next slide. So as for the causes, as you can find from fundoscope, the first one, retrobulbar neuritis, the optic nerve is affected more posteriorly. Sorry, I want to correct what I just said just now, like what Dr. said. The optic nerve head is not affected, but the optic nerve can still be affected. But there is no de-swelling. Basically, you can find any findings under fundoscope. The second one is papillitis. Papillitis affects the optic nerve head, and you can see edema of the optic disc and also peripapillary flame-shaped hemorrhages. And the third one is neuroretinitis, which is basically papillitis plus the involvement of macula. And you can see a macular star figure composed of hard exudates. And this commonly, it is associated with viral infections, such as viral infections and also bacterial infection, such as head scratch fever, syphilis, and also Lyme disease. It is usually self-limiting and resolve in 6 to 12 months. So, and also neuroretinitis is rarely a manifestation of demyelination. Next slide. So this is basically a summary and also the conclusion and of differences among the three kinds of ophthalmoscopic classification of optic neuritis. So as you can see on the retrobulbar neuritis, the optic disc is actually normal. We cannot see any findings. So the condition is actually described as the patient sees nothing and also the doctor sees nothing. It is a most frequent type in adults and also frequently associated with multiple sclerosis, which is the most common kind of demyelination disease under optic neuritis. And the second one is papillitis. Papillitis, as you can see on the optic disc, there is edema, and also there is peripapillary flame-shaped hemorrhages surrounding the optic disc. It is a most common kind of optic neuritis in children and also in Malaysia. And we need to rule out any infectious causes for papillitis. As for neuroretinitis, actually is a concomitant swelling of an optic nerve head, which is papillitis, and also the involvement of macula. So you can see macular star because there is hard exudates being secreted surrounding the macular region, as you can see from the temporal side of the fundus. So it gives an appearance of a star. And it is a least common type. It is rarely due to demyelination disease, and mostly it is due to viral infection or bacterial infection, such as head scratch fever. Right, next slide. So this is actually just a figure to illustrate what I just said just now. As you can see in the diagram, the one I'm zoomed in is the part of optic nerve head. So optic nerve head by means it is involved in papillitis and also neuroretinitis, whereas in retrobulbar neuritis, the optic nerve head is not involved. So as you can see, that it is divided in a few regions, which I'm not going to discuss. I only want to point out that the lamina region is the lamina cribriform discussed by Nisa just now in papillary edema. This is a region which is compressed. And as you can see, the optic disc is presented in the superficial nerve fiber layer. So we cannot see if there's no abnormalities over that region, which happens behind the optic nerve head, which is in the case of retrobulbar neuritis. Next slide. Next. Right. As we have discussed just now, retrobulbar neuritis, as you can see in the diagram, is actually the optic disc is actually normal with a pink appearance, with a well-defined age, and this condition is actually described as the patient sees nothing and the doctor sees nothing. So as you can see, there's something like pigmentation, but it is normal, especially in our population. Next slide. So this is actually a presentation of papillitis under fundoscope. As you can see, there's a swollen disc in the middle. You cannot actually see the edge of the disc. The edge of the disc is not well defined, and there is blurring and hyperemia of the disc margin. As you can see, there's a redness for this margin, and you can see the venous, the veins are dilated and engorged. They are way more thicker than the arteries, and there's also flame-shaped hemorrhages surrounding the optic disc. So you might find cotton wool spot and also secondary optic atrophy under fundoscope. Next slide. So this is a presentation of neuroretinitis under fundoscope, right? So we want to point out two things over here. First, we look at the optic disc. As you can see, the optic disc, there's no well-defined margin as well because edema has already infiltrated into optic disc. And you can see the macula is actually a starlight area because hard exudates form a star-shaped pattern surrounding the macula. Right, next. All right, next we'll move on to etiological classification as we have finished discussing the classification under ophthalmoscope. Now we proceed to the causes. First cause is demyelinating causes. So the pathophysiology is that the myelinated nerve fibers lose their myelin layer because most probably due to multiple sclerosis, which is an autoimmune kind of condition. So the myelin is phagocytosed by microglia and also macrophages, and also and then to heal the nerve, astrocytes will lay down fibrous tissue and it will form a plaque. So it will disrupt the nerve conduction in a white matter. Because the myelin sheet is gone, there's no more node of Ranvier for the action potential to jump. So instead they have to like walk along the nerve, so it is slower. So the most common age is middle age from 20 to 50 years old. The ratio of female to male is 3 to 2. And the most common cause is multiple sclerosis in this case. And the optic disc is actually normal. So it is a kind of retrobulbar neuritis. Next slide. So next we'll be discussing on multiple sclerosis. So it is actually a type 4 hypersensitive kind of autoimmune disease. It's a remitting idiopathic demyelinating disease in the CNS. So because it is type 4, it comprises of T cell activation, and it will attack and also disrupt the myelin. So these are some of the symptoms of multiple sclerosis. In the eyes, we have nystagmus, optic neuritis, and also diplopia, depending on the nerve affected. All right, next slide. Right, next, another cause is para-infectious. Para-infectious is most common in children. It occurs because of exposure of antigen of certain infectious agents such as measles, mumps, chickenpox, rubella, whooping cough, and also glandular fever. It can happen actually following immunization of vaccination. So it usually happens 1 to 3 weeks following viral infection. So the timeline is very acute. It will be presented with acute severe visual loss. So usually bilateral eyes will be involved, and papillitis will be the presentation under fundoscope. As we discussed just now, papillitis is the most common kind of optic neuritis in children, and para-infectious is the cause. And spontaneous recovery within few weeks after getting bilateral papillitis. It may be associated with other neurological features such as headache, seizures, or ataxia, which commonly happen in meningoencephalitis. Next will be infectious. Infectious, we have sinus-related optic neuritis. It could be due to bacterial infection, such as in cat scratch fever, syphilis, TB, toxoplasmosis, cryptococcal meningitis in patients with a compromised immune system, such as in AIDS and also herpes zoster. So the last one is non-infectious, which is autoimmune. Non-infectious, we have sarcoidosis, which under fundoscope, the optic nerve sheath will exhibit lumpy appearance, and also inflammatory reaction in the vitreous. And the next one is systemic autoimmune disease, which more commonly will be presented in retrobulbar neuritis. So the examples of autoimmune diseases are SLE, polyarthritis nodosa, and also other vasculitis. Right, next, move on to a clinical presentation. So as we have discussed just now, the clinical presentation of optic neuritis most commonly happen in adults in middle age. So usually women is a risk factor towards optic neuritis, and they'll be presented with acute unilateral loss of vision compared to bilateral, but bilateral can happen also. It will progress over a few days and then slowly improve. And the pain will also be exacerbated on eye movement, especially in retrobulbar neuritis, because the rectus, the muscle of the eye, will contract and also pull on the optic nerve sheath. And next one will be a change of color perception. In this case, medically, it is called dyschromatopsia in the affected eye. So next slide. So there could be a preceding history of viral illness, such as in children especially, because we can recall para-infectious normally happens in children. Vision loss exacerbated by heat or exercise. This condition can happen in demyelinating diseases. More specifically is the multiple sclerosis. So when the patient is exercising or taking a hot bath, the vision loss will be exacerbated. It is called as a Puthoff phenomenon, because myelin sheath is already destroyed. There's no there's no node of Ranvier for the action potential to jump, and it will travel into a nerve. So in this case, there will be a disruption in action potential. The sodium gate will be closed, and the potassium gate will be open. The excessive efflux of potassium. So that's why there's a loss of core body temperature control. And 40 to 70% of patients will have other neurological symptoms, such as paresthesia, weakness, incontinence, and it will suggest the diagnosis of multiple sclerosis. Next slide. As for examinations, we can test for the visual acuity of a patient. Normally, there will be reduced visual acuity, or there will be no light perception at all. And there will be reduced color vision, and there will be also relative afferent pupillary defect, which is known as a Marcus gun pupil in the affected eye. And there will be visual field defect. Most commonly is central scotoma or paracentral scotoma, and also reduced brightness. But then in retrobulbar neuritis, there will be a normal disc, papillitis, and also neuroretinitis. There will be a swollen disc. Right. So next slide. As for diagnosis, the diagnosis of optic neuritis is mainly clinical. So these are certain investigations directed to rule out the causes based on the classification of optic neuritis. So first one, serological test. You can do FBC to find out if there is any infectious causes. ESR is normally elevated in multiple sclerosis and also other autoimmune diseases. And you can do certain investigation to rule out autoimmune diseases such as ANA, ANCA, and also RH factor. And you can do infectious studies, VDRL, torches, Bartonella. Bartonella is an agent for head scratch fever. And chest X-ray, Mantoux test to rule out TB. And also the last one is CSF analysis to find out multiple sclerosis. Right, next slide. Right, so for multiple sclerosis especially, we can use MRI to find out the cause and if there is optic nerve inflammation. So the MRI of the brain and orbits with gadolinium contrast has become the cornerstone of evaluation in patients with optic neuritis. So basically, this is the most effective kind of investigation. So it is to confirm the clinical diagnosis. There will be plaques of demyelination under optic neuritis. So it will offer a very strong prognostic information about a risk of future demyelinating events and multiple sclerosis. Basically, this sentence, this statement, this says that normally patient with multiple sclerosis will be presented with optic neuritis. So if you have optic neuritis, most probably in the future you'll get multiple sclerosis. But then based on the research in HUSM by Prof. Shatria, very few Malaysians actually has this association between multiple sclerosis and also optic neuritis. I'll show you the research results later. And this most commonly happens in the US. So we have to rule out atypical optic neuritis through MRI also. Next slide. So this is the figure of MRI result of brain and also optic nerve. As you can see on the left red arrow, there's a white matter lesions or plaques inside the brain and inflammation of optic nerve. So I'm sorry, the white matter lesions is on the right, whereas the inflammation of optic nerve is on the left. So we need to use and contrast enhance fat saturated T1 mix scan. So basically, fat saturated, we have to suppress the fat, whereas the T1 mix scan is can show you the most normal anatomy of the brain and the eye under MRI. So basically, you show a bright enhancement of an inflamed optic nerve. So if there's any bright spots of it is most likely suggestive of multiple sclerosis, as you can see at the lower right red arrow. Next slide. So if you don't suppress, this diagram is actually just to show you why we need to suppress the fat under MRI. Because our eye is basically surrounded by layers of fat. So if we don't remove the fat under MRI, you cannot see clearly the optic nerve. Right, next. So the principle of management is actually to treat the underlying cause. So back to our classification of etiological causes of optic neuritis. So basically, for infection, then we need to treat the causes. You know, find out the infectious agent and also treat accordingly. Next slide. So in this case, if it is non-infectious, we have a standard regime, which is we give IV corticosteroid, 250 milligrams 4 times per day for 3 days. And also oral corticosteroid, 1 milligram per kg per day for 11 days. And we need to monitor the optic nerve function and also in infectious causes, we treat accordingly. Next slide. So basically, this is the result of research done in USM over 5 years review. So I'll just briefly read out the summary of the result. So the result actually comprises of 31 patients in this 31 patients, we have 41 eyes being researched on. And females are the predominant group in this case. And the age peaks at 21 to 30 years old for optic neuritis. And 2/3 of a patient had actually unilateral involvement of one single eye, and the pain on ocular movement was observed in 31 or 1/3 of a patient of the affected eyes, whereas around 2/3 of the eyes showed visual acuity equal to 6/60 or worse on presentation. So, and also paracentral scotoma was the most common visual field defect noted. Optic disc papillitis is more widespread in the Malaysian population. And the most common etiology was idiopathic, which is more than 50%, whereas multiple sclerosis is only 3.2%, which is extremely low in our population. But then you can compare among the few countries, the highest etiology of multiple sclerosis in optic neuritis is in USA. So in other countries, basically, it's quite low also. Right. So next slide. Basically, this is the data of the research. You can go and read yourself. So this is the end of our presentation. Thank you.
Okay, so I will proceed with the ischemic optic neuropathy. Next. First, we must know the anatomy of the optic nerve. The optic nerve is divided into the 4 segments, which are the intraocular, intraorbital, intracanalicular, and also intracranial. The intraocular segment is only 1 millimeter long, which is very short, and it lies within the retina and emerges through the scleral opening at the lamina cribosa. And then for the intraorbital segment, it is the longest part, which is around 13 millimeter. It passes posteriorly and then centrally within the orbit, and it also surrounded by the dural lining and also CFCS. So it directly communicates with the subarachnoid space, and that's why when there is increased pressure from the hydrocephalus, the papilledema will occur. And then intracranicular segment is around 6 to 9 millimeter long, and this is where the optic nerve exits through the optic canal that is superior to the ophthalmic artery. And then the fourth part is the intracranial segment, which is 10 millimeter long. It enters the middle cranial fossa, and then it will join with the actic chiasm. Okay, for the blood supply, the optic head is supplied by the branches of the ophthalmic artery, which is originate from the internal carotid artery, as we know. And then the central retinal artery is one of the branch of. Yes. So I continue. The central retinal artery is one of the branch of the ophthalmic artery. It runs along the inferior aspect of the optic nerve, and then before it penetrates the optic nerve, which is posterior to the. Yes. No. So doctor, I cannot hear you. Hello doctor, can you hear me?
Okay, can hear already.
Okay. Um, so should we okay, I proceed with this slide lah. So the ischemic optic neuropathy is defined as loss of vision due to the damage of optic nerve from the insufficient blood supply when there is blockage to that blood supply. And there are two types actually, which is anterior and posterior ischemic optic neuropathy. However, I will only the anterior ischemic optic neuropathy will be discussed. So this anterior ION involve 1 millimeter segments of the optic nerve head, which is I told before, and this will result in the visible deswelling. Okay, next. So the difference between anterior and posterior is that anterior affect the optic disc and also the optic nerve that is supplied by the posterior ciliary artery, while the posterior is ischemia in the posterior part and also other part of the optic nerve. This is less common than anterior. The anterior ION is then further divided into the arthritic and also non-arthritic. Next. Okay, so what is non-arthritic and what is arthritic? The causes for non-arthritic is caused by the acute impairment to the circulation of the arteries that supply the optic nerve. So this will reduce the supply to the short posterior ciliary arteries, which can result in partial or total infarction of the optic nerve head. And then the arthritic, it is caused by the giant cell arthritis, GCA. And this is what differentiates it from the non-arthritic. So in arthritic, there is giant cell arthritis. This GCA is inflammation of artery, medium-sized artery that most commonly occurs in the elderly. It most commonly affect the superficial temporal, and that's why it also known as temporal arthritis. However, the GCA also can affect the ophthalmic and posterior ciliary artery. This will give rise to the ischemic optic neuropathy. Epidemiologically, the non-arthritic is more common than arthritic, and it involves the younger group of population between the age of 45 to 65 years old, and it also affects more male than female. And then the non-arthritis is the most common cause of the sudden optic nerve that related to the loss of vision. Okay, for the arthritis, it is less common compared to the non-arthritis, but it is more dangerous and also is considered as medical emergency as it will result in some severe systemic and also ocular complication. It also have poor prognosis as the visual loss is usually permanent. It involves the older population, which is the age of more than 65 years old, and also more common in women. It also associated with more morbid condition, and this include blindness, stroke, and also myocardial infarction. For the risk factor for non-arthritic is hypertension, diabetes mellitus, collagen vascular disease such as SLE, rheumatoid arthritis, and also hyperlipidemia and smoking. And then the risk factor for the arthritic, this includes increased age, as I said before, those who is older than 65 years old, the female, those who have polymyalgia rheumatica, PMR, this is inflammation of the muscle where there is pain and stiffness in the proximal muscle groups, usually at the shoulders and the bicep. And the patient may complain worse pain when waking up. And then about 50% of patient, half of the patient with GCA also have polymyalgia rheumatica when diagnosed. And then another 20% of the PMR patient will later develop the GCA. Okay, next. For the clinical features, in the non-arthritis patient, they may complain of molecular loss of vision, which is sudden and painless. It usually discovered upon echoing up in the morning. The vision loss is often altitudinal field loss, which involve the upper or lower half of the vision. So the sign during the ocular examination, the patient may have signs such as there is slightly decreased visual acuity, but it can also be normal. So the and the visual field, there is visual field defects which are typically the inferior altitudinal, but there may be also the central, the paracentral, the quadrantic, this 1/4 of the vision, and also arcuate defects can also be seen. For the fundoscopy, the finding may show that there is small cut to this ratio, which is less than 0.3. There also may be diffuse or sectoral pale swelling that is associated with a few peripapillary splinter hemorrhage. I will show the picture later. And then for the arthritic ION, the patient may complain of ocular symptoms such as sudden, profound unilateral vision loss that involve the one eye with flashing of light. There is also a periocular pain, which is very common as well. The most cases occur within a few weeks after the onset of GCA. So GCA onset first, and then we occur the arthritic ION. And then the patient also have GCA manifestation. For example, scalp tenderness and also headache. Okay. The sign for arthritic ION are reduced visual acuity, and then when see the optic disc, it is observed as chalky white, pale, and also swollen. They may also have splinter hemorrhage on the margin of the optic disc, and we can also see the prominent temporal arteries at the temporal region at the head of patient. Okay, next. This is the image that shows a swelling of the optic disc, which is gradually resolved, and then the pallor will occur 3 to 6 weeks after the onset. On the second picture, it shows splinter hemorrhage at the prepapillary region. As you can see, the hemorrhage is like longitudinal, panjang. Okay, next. This is the fundus for arthritic ION. So when we see the optic disc, it is pale in color, it's swollen with irregular margin, and also have striking chalky white appearance. Okay, next. The investigation for non-arthritic ION are first measure the blood pressure and also glucose level, as the hypertension and diabetes mellitus are the risk factor for this. And also do the fasting lipid profile test because a person with hyperlipidemia also at risk. For the neuroimaging, it is usually unnecessary, but MRI brain and orbits can be done if the patient has significant pain, especially at the ipsilateral eye movement. And this is to exclude the optic neuritis and also multiple sclerosis. For the management of the non-arthritic ION, as for now, there is no effective treatment yet, but we can reduce the progress and the risk for further vision loss by treat the underlying systemic predisposition, the underlying cause. So this can also protect the other eye that is not yet affected. This is because in about 3 years, almost 20% of the patient are at risk to improve of the other eye. For the investigation of the arthritic ION, first measure the ESR, which is erythrocyte sedimentation rate. Usually, the ESR will be high due to the inflammation with level more than 60. But some of the patients, they may have normal ESR. So, in case of this, C-reactive protein test can be done. So, it should have high CRP result. And this CRP is also helpful if the ESR just now show normal or low result. Okay, so other tests will also include the platelet count for possible thrombocytosis. Superficial temporal artery biopsy is also recommended if there is suspected arthritis. So the positive biopsy findings, we will see the positive biopsy findings such as internal thickening and also inflammatory chronic inflammation of with giant cells, which is positive for GCA. The fluorescein angiography can also be used to confirm the diagnosis of the arthritic ION. It will show hypoperfusion of choroid, which means that there is delay choroidal filling. For the management of the non-arthritic, the goal is to prevent the blindness of the fellow eye by giving early steroid treatment. For example, give intravenous methylprednisolone, which is given 1 gram per day for 3 days consecutively, and then give oral prednisolone with dose 1 to 2 milligram per kilogram of the patient per day, and then after 3 days, the dose will be reduced to the 60 milligram. Antiplatelet therapy, such as aspirin, can also be started as this has shown that it can reduce the risk of visual loss and also stroke. Okay, next. Next is the giant cell arthritis just now. It is granulomatous necrotizing arthritis that usually affect the large and also medium-sized arteries, often the major aortic branches and also the superficial temporal artery. Also involve the ophthalmic, posterior ciliary, and also proximal vertebral arteries. The severity and the extent of the involvement are associated with the quantity of the elastic tissue in media and also adventitial layer of the artery. The intracranial arteries are usually not affected as they have little elastic tissue, whereas the aorta and the other branch they have more elastic tissue. The next. Okay, those who have GCA, they may come with complaint of first is scalp tenderness, which is first noticed when the patient combining the hair, and this is very common symptoms. Okay, next one is headache. The headache can be localized at the frontal, at the occipital, or at the temporal area, but it also can be generalized headache. There also jaw claudication, which is cramp-like pain when the patient speak or chewing, and this caused by the ischemia of the masseter muscles. Next is polymyalgia rheumatica, which is inflammation of the muscle. And then the patient may also have non-specific symptoms such as neck pain, weight loss, fever, night sweat, malaise, and also depression. Superficial temporal arthritis can also be seen, which is characterized by the thickened, tender, inflamed, and nodular arteries, as shown in the next slide. The next slide. Okay, this is the pictures of prominent temporal arteries, which is very visible and is usually painful when palpate and have no pulse. Next. This is a HPA of the GCA, which shows part of the arterial wall. This is taken from the superficial temporal artery. The first picture shows there is chronic inflammation of the lumen. And then in the second picture, we can see that there are multiple multinucleated giant cells. Next. Okay, this is the last part of the presentation, optic atrophy. Optic atrophy is a result from the degeneration of the optic nerve. It is not a disease, but actually a sign of late stage of more serious condition of the optic nerve. So for the clinical features, the visual acuity is reduced but can also be normal, and this will depend on the degree of the optic atrophy. In this patient with mild optic atrophy and has apparently normal visual acuity, the color vision can be reduced and also can be presented with the visual field defect. The patient may also have a relative apparent pupillary defect, just like how Lisa explained before. And then there is also dispeller, which is in severe optic atrophy, the entire disc seen as pale. However, in some patient, in some case, there's only some part of the disc that is affected. For example, at the temporal part only. And that's why we need to compare both of the right and the left disc to detect any abnormality. Okay, next. Okay, this in this picture, the entire disc, we can see that it is pale in color. That I think we can appreciate the cup as everything is pale. Okay, next. Okay, for the etiology, there are many etiology for the optic atrophy. It can be from the hereditary optic neuropathies, such as Leber's hereditary. This is inherited form of the vision loss. It also can be caused by the retinal dystrophy, such as cone dystrophy, which is manifested by the very poor visual acuity, have reduced color vision, photophobia, and also central scotoma with nystagmus. It can also caused by the vascular, such as central retinal artery occlusion, especially in person with history of angina or peripheral vascular disease, and together with the sudden loss of vision. Next is toxic and nutritional optic neuropathies. For example, vitamin B12 deficiency. This is characterized by the gradual bilateral visual loss associated with the pins and needles in the hands and also feet, and also with the podaya and reduced color of vision. Can also caused by the inflammatory causes such as sarcoidosis. In this case, the patient may more commonly present with the disc swelling. And then demyelination. So the patient may have past history of typical attacks of optic neuritis or other neurological symptoms. This is a common cause. And the last one is the compressive cause. For example, orbital tumor or intraocular tumor. The next. Okay, for the management, there is actually no specific treatment for optic atrophy. But the only way to prevent the optic atrophy is by treating the underlying cause. For example, if there is intraocular pressure, we must control. If there is intraocular pressure, control the pressure in the glaucoma patient. Or if the patient has sarcoidosis, control the inflammation. And then for those who have strong family history of eye disease, it is recommended to do regular eye checkup to detect any abnormalities as soon as possible. I think that's all from us.
Okay, one of the things with optic atrophy is that you need to treat the underlying causes. So to treat, you must find the cause first. So in those patients who come with earlier on with optic disc edema or papillary edema, obviously you will investigate. But in those patients who come perhaps for visual disturbance for long term, and then when they come with already atrophic disc or optic disc atrophy, you still need to find out the cause. Okay, because sometimes the cause can be due to the space of dilation. I mean, like some tumor, probably pituitary adenoma. So we still need to ask regarding the systemic symptom as well, and then perhaps we can still do CT scan or any imaging to look for the possible brain lesion or brain tumor causing the optic disc atrophy. Okay. 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 Now we open the session to questions. Supposedly banyak question you all boleh ask. I don't know kalau memang everybody understand the presentations, perhaps tak banyak lah. Okay, boleh je nak tanya apa-apa. I'll try to answer. Okay, before I forgot, can please open up the slide first tadi yang the first presenter. Because I need to correct regarding the binocular vision. The one yang I ni showed earlier on. Sebab I rasa I ni tunjuk silap tadi. Third slide. Okay, alright. So, sorry yang tadi. The previous slide please. Okay, this one. Okay, jadinya binocular vision ni, binocular field is when you open both eye, you are looking with two eyes. Okay, we are looking when you are looking in both eyes. In those yang tak ada screen, okay. Those with screen usually they don't have binocular field. Sebab dia akan ada some problems lah. Okay, so easier to say binocular field adalah the vision yang opposed from two eyes yang dia overlap. So where is the binocular field? The binocular field is the light blue, not at the center. Okay. So kalau you close one eye, when you close one eye, the whole view is monocular field, monocular view. When you open two eyes, so the overlapping. Okay, the overlapping tu adalah the binocular field. Actually the gambar ni pun tak, because the gambar focusing yang dekat tengah is not very accurate. But you can try on your own. You just close one eye, so the whole view yang you nampak adalah monocular. By the time you open up binocular vision, bila you open the other eye, so you look with two eyes, you akan notice you punya nasal field of the other eye pun macam bertambah. Okay? Alright. So itu saja yang I nak bagi tahu. And always remember whatever it is for the pupillary reflex, for the accommodation, whatever the innovation is, dia akan include two eyes. Mesti ada ipsilateral and contralateral because God works in mysterious ways. So perhaps one eye is diseased, so we have another eye that can compensate the other eye problems. Okay, so it's good to know that. Tak ada soalan ke? Bagus ni. First time tak ada soalan untuk tutorial 6. Oh, sebab tadi the presenter already asked perhaps. Okay, alright. The common questions usually asked, you don't have pro exams. For Opta, it will be in the SEM 8 punya exam. So among the possible, yang always being asked regarding the Neurophtal regarding this tutorial 6, usually the visual pathway tadi, the visual field defect. So jangan tertukar right and left. Right is always, walaupun gambar, kalau kita tengok anything on the right, on your right arm is right eye, on your left is left eye. So jangan tertukar that one. So, you need to know every single visual field defect, the name, where the locations, kat mana the lesion or the defect is. Itu the favorite questions lah. And then regarding the pupillary light reflex pun very important. Okay, because kita ada Edinger-Westphal tadi tu. So you need to know the Edinger-Westphal tu, is it sympathetic atau parasympathetic of the third nerve. Okay. So you need to know every level of that. And then regarding the accommodations, because accommodation dia ada 3 triad. So kalau you look at the 3 triad, the 3C, it's convergent, constriction, and another C is
Which of lens?
sorry,
Which of lens?
convergence of the lens. Yes. So what happened in convergence? What happened in accommodations? Accommodation, when your eye try to accommodate from distant view, from distant object, from distant vision to the nearer one. But bila tengok jauh, your eye is relaxed. Okay, so bila you nak ubah position from looking far to the near, so what involved? Daripada jauh, mata you macam akan tegak, it slightly diverge. But when you are looking near, you akan nampak mata pun akan masuk ke dalam. So it is the involve you punya medial recti, akan ada medial recti pun contraction. So this medial recti contraction, the aim is to bring, sebab kita nak fokuskan the object to the light, the image on the fovea. Kalau your eye remain at the slightly diverge, tapi the object already near, so you akan nampak macam blur lah kan. Kalau you tengok jauh tapi you letak tangan kat depan, you tak nampak clear pun dia. Okay, and then what happen next? Because it's the third. So third tadi, third cranial nerve pun kita kata dia akan menyebabkan constriction of the pupil. Sebab medial recti is innervated by the third kan. And then at the same time akan ada constriction of the pupil. Why need to constrict? Kita nak increase depth of focus. Itu satu. Satu lagi, remember the visual acuity class? Kalau you punya pupil is dilated ataupun besar, akan ada aberration. So ada macam like banyak reflection on the eye. So kita nak kurangkan that one. Jadinya the pupil need to be constrict. Sometimes dia boleh constrict up to down to 2 mm. So dia macam resemble macam pinhole effect macam tu lah, dia akan mengecil. Okay. Tapi in those yang ada traumatic mydriasis ke apa, yang perhaps dah gone dia punya innervation on the sphincter muscles, the eye tu tak akan mengecil despite of you punya accommodations. Okay, then convergence of the eyeball. So convergence tu yang tadilah the medial recti contraction, and then curvature of the lens increase. So maksudnya you punya ciliary body muscles tu akan relax, so that you punya lens akan membesar. So dia akan fokus image slightly ke depan. So dia akan increase power of the lens lah. Okay, so these 3 triad you need to know. Other than that, all the diseases. Okay. So kalau tak ada any questions, kita nak habiskan the session. Your next session will be 11:30 kan? So sorry sebab kita terpaksa start lambat tadi.
I think there's no more question, Doctor.
Okay, alright. So thank you Nisa for arranging, for appointing the presenters. Thank you Aini and Bushra for your presentation today. So perhaps, okay, we can end the sessions. Any issues, any problem, you can just text me perhaps. If I can answer, I'll try answer it. Okay. So that's all. Thank you everyone.
Thank you,
Thank you,
Doctor.
Doctor.
Thank you, Doctor.
Thank you, Doctor.
Doctor.